1 in 4 people in the world is thought to suffer from non-alcoholic fatty liver disease, or NAFLD. You might even have it and not realize it, but something so common shouldn't be much cause for concern, right? NAFLD is defined as an excessive buildup of fat in the liver for reasons unrelated to alcohol use. In 2020, an international team of experts suggested changing the name from non-alcoholic fatty liver disease to metabolic dysfunction-associated fatty liver disease, or MASLD. This term focuses more on the underlying disorders in lipid metabolism that not only increase the risk of cirrhosis and liver cancer, but are also associated with a higher risk of cardiovascular disease. Fatty liver is characterized by increased synthesis and storage of triglycerides, but the presence of excess triglycerides in the liver is not by itself intrinsically harmful. However, in combination with metabolic disorders such as obesity, type 2 diabetes, and dyslipidemia, the risks increase dramatically. This is the so-called two-hit hypothesis. The liver can tolerate excess fat until an inciting factor occurs that triggers inflammation and results in cycles of tissue damage and repair. The liver is remarkably resilient, and the process can be reversed, but only up to a point. To explain what goes wrong, let's look at how the body metabolizes fat. Most nutrients are absorbed in the small intestine and carried directly to the liver through portal circulation, but not fats. Why not? In part because they're hydrophobic, but also because they tend to be too large to enter intestinal capillaries. Having said that, short and medium-chain fatty acids are small enough to enter capillaries and are transported to the liver bound to albumin. But long-chain fatty acids, cholesterol, and other lipids are too large to be transported this way and are processed differently. In the lumen of the intestine, conjugated bile salts form micelles that emulsify liquids, breaking them into smaller droplets and increasing the surface area for pancreatic lipase to act. Fatty acids, glycerol, and other lipids are imported into enterocytes and packaged into chylomicrons. Chylomicrons are triglyceride-rich lipoproteins that are used to transport ingested lipids from the intestine directly to targets throughout the body. Chylomicrons are too large to enter capillaries and are instead transported through lymph vessels as a milky liquid called chyle. Chylomicrons enter systemic circulation via the thoracic duct and are used directly by skeletal muscles in the heart. The excess is stored in adipose tissue. White fat cells are unilocular lipocytes that store fat in the form of triglycerides and cholesterol esters in a single large fat droplet. Lipoprotein lipase breaks down triglycerides from chylomicrons into free fatty acids for import into the cell. The cell converts them back into triglycerides for storage in the process of lipogenesis. When blood glucose levels increase, the pancreas secretes insulin, which induces adipocytes to increase import of glucose. Insulin also suppresses lipolysis, which is the breakdown of triacylglycerols into glycerol and free fatty acids. Together, this reduces the level of glucose and free fatty acids in the blood. Adipocytes also release adiponectin, a protective compound that regulates glucose and lipid metabolism and helps prevent inflammation and fibrosis. Through chylomicron delivery, most ingested lipids bypass portal circulation and are not processed in the liver. However, chylomicron remnants, which still contain triglycerides, remain in circulation and are eventually cleared in the liver. The liver also tends to accumulate fat when metabolizing a high fructose diet. When not immediately used to produce ATP, fructose is converted into glyceraldehyde 3-phosphate and used to synthesize triacylglycerols and very low-density lipoproteins, or VLDLs, for export. As the amount of stored triglycerides increases, liposomes enlarge, displacing the nucleus to the periphery. This is visible as macrovascular steatosis on biopsy and increased echogenicity on ultrasound. But at this point, the condition is still reversible. It may remain asymptomatic for years, but at some point, a second hit may occur. To cope with excess fat, the number of adipocytes can increase through adipogenesis, but only until around age 24. After that, the number of adipocytes remains relatively constant, even if they are no longer needed. More importantly though, after that point, adipocytes can only increase in size instead of in number to accommodate additional fat. Unfortunately though, adipocyte hypertrophy is maladaptive. Adiponectin levels drop, and oxidative stress and apoptotic cell death can occur, leading to release of pro-inflammatory cytokines. Hypertrophied adipocytes eventually stop responding to insulin, resulting in the release of free fatty acids into circulation. Although accumulation of excess triglyceride leads to fatty liver, triglyceride storage is considered an adaptive mechanism that does not cause hepatocyte injury. However, free fatty acids are another story. Insulin signaling in the liver normally inhibits gluconeogenesis and promotes glycolysis. In a healthy liver, insulin signaling also inhibits fatty acid oxidation and promotes de novo lipogenesis, in which carbohydrates are converted into fatty acids and triacylglycerols. However, insulin resistance selectively disrupts the effect of insulin on glucose metabolism, but it does not disrupt its effect on lipogenesis. Therefore, insulin exacerbates steatosis both through insulin resistance as well as through hyperinsulinemia, as insulin levels rise more and more to try to compensate for resistance. Fatty acids bound to acyl-CoA undergo beta-oxidation in the mitochondria. This excess of fuel causes mitochondria to become hyperpolarized, which increases the half-life of oxygen carriers in the electron transport chain and generates reactive oxygen species. Hepatocytes experiencing severe oxidative stress may undergo apoptosis or necrosis, resulting in inflammation and cycles of injury and repair that may be associated with elevation of liver enzymes such as alanine transaminase or ALT. The liver transitions from a state of benign hepatic steatosis to a much more dangerous, eventually irreversible condition called steatohepatitis or NASH. The morphology of fat droplets changes, resulting in ballooning hepatocytes and the appearance of Mallory-Denk bodies. A high-fat, high-fructose diet is also associated with maladaptive changes in the gut microbiota. Gut dysbiosis results in exposure of the liver to bacterial products such as LPS and induces Kupffer cells to secrete pro-inflammatory cytokines that activate hepatic stellate cells. Once hepatic stellate cells are activated, the process approaches the point of no return. Instead of healthy hepatocytes proliferating to replace injured hepatocytes, activated hepatic stellate cells differentiate into myofibroblasts and begin to permanently remodel the extracellular matrix. Initially, collagen fibers are deposited close to the central vein in zone 3, where the effect on liver function is relatively modest. However, collagen is eventually deposited in the space of discs, leading to paracellular chicken wire fibrosis and bridging fibrosis. 16% of the volume of the healthy liver is empty space, allowing sinusoids to quickly adapt to changes in intrahepatic pressure to maintain portal blood flow at a manageable rate. As the liver stiffens, it becomes less adaptable, leading to portal hypertension and cirrhosis. To relieve pressure, portal blood diverts into smaller vessels, creating portosystemic shunts and resulting in dangerous complications such as ascites and esophageal varices. A critical role of the healthy liver is detoxification, including the removal of ammonia. But when portal blood begins to bypass the liver, the concentration of ammonia in the blood increases, causing hepatic encephalopathy and coma. The liver's intricate architecture is gradually eroded by fibrotic scar tissue, and unprocessed blood from the portal vein begins to seek out shortcuts, bypassing the congested sinusoids and deteriorating hepatic zones of the liver. At this stage, the risk of hepatocellular carcinoma increases sharply, and without liver transplantation, the liver will eventually fail. This is a grim outcome, but only a small fraction of people will progress to this point. Nonetheless, fully 1/4 of the world's population find themselves somewhere along this trajectory, making it one of the most critical long-term public health challenges. Research on this topic is intense, and few diseases offer a better chance of complete reversal through simple lifestyle changes. Despite the complex pathophysiology of this disease, the single most important factor is fibrosis. Therefore, if this critical stage can be delayed or reversed, millions of lives may be spared.